All right. Here we are. And for all those fortunate to be in attendance, let us discuss what's going on. So it's going to be comparatively brief. The only thing I missed a doctor's appointment yesterday. Totally forgot about it. First day my wife and I actually had a chance to day together. I don't even know how long. Thanks to my stepson stepped up, took care of his grandma. Attaboy. Nevertheless, so what I'm going to show you, I'm going to be before I need to finish the blood vessels. This is the name the blood vessels part of the program. But what I'm going to do is I'm going to buzz through so you'll have a video record of the slides. Next week, I will set up a labeling practical here. I'll tell you what slides what slides we're going to use and why I am being nice to you, I don't know. Everybody can have a 4x6 card, both sides, with additional information that you might find helpful. Not to be confused with a cheat sheet, but additional resource information that you may construe as being helpful. Unless there's, yes.
Just like a diagram.
You can make diagram. I have seen people staple things to it. That's why you're students and I'm not. We couldn't use that stuff. Way back, I realized we actually didn't have quills for pens. They didn't have outhouses. I want you to understand that. But no extra help was allowed. But for whatever reason, I've chosen to be pleasant to you. But that can change suddenly without notice. Particularly if someone sitting in this row doesn't smile at me once. Named Riley. I don't want to pick anybody out. I don't want to pick anybody. So, for those recently in attendance, and I'm delighted to have you here, I'm going to buzz. These are the illustrations you're going to see. There'll be more than you're going to see. Typically with these labels, effectively, I call it a practical. It's a labeling exercise. It's not, Bones practicals inherently are, it's just too tough. I've never really gone for people having a piece of a heart, like a sheep heart with a pin in it and a little flag, so this way at least I can know that you'll at least have done some work to become familiar with this. Not that you wouldn't have done it anyway, but I will start to buzz through this. I know I'm presenting. Thank you very much. Stop it. I don't care. Okay, so I'll do the hard one first because that's up. And I know we did this already, but I'm just scrolling through these to look for illustrations that I might use. And really for the heart, there's only a limited number. And it wouldn't necessarily be that. It's ones that I have reproduced in the past and used. So something like this, you want to write down the numbers, that's fine. I'll just voice the numbers. 17.2C. So what I have a program, we all do, when we get this, that we can print these without the labels on them and put in our own labels. I print them up in color upstairs. The dog and I, he likes to work with me. Probably not. I don't think so as much as I will like that. It's coming. Probably as 2 or 3 times easy for 17.5E because you can do the chambers, you can do the vessels, you can do the valves, chorda tendinae, papillary muscles, pectinate muscles, So you see this minimum of 2 times, I'm sure. Like I said, I put out stations with these, and we kind of play musical chairs. And everybody has a chance to go back. We just go through a minute at each station and then make your way back. If you need more time, and that's fine. And there's probably going to be 3 responses at each station. I'll have the answer sheet and all that good stuff. So this one, yes, 17.5B. Again, I can focus on vessels. I can do the oracles, etc. Those, you can see that there's an ample supply of stuff. And this one as well, 17.5D. That's the posterior aspect. You have the cardiac veins, the coronary sinus, the pulmonary veins, the opening for the inferior vena cava, superior, etc. You saw that one already. Again, like I said, you see it a lot. So there are only a couple more here that you'll see. And not that one with the valves or that. It's coming. It's the one with the arteries. This guy, 17.10A. So I utilize, left, right. You can have the anterior interventricular, you have the marginal, you have the circumflex. There's enough arteries there to deal with. I generally don't use that. Okay, so that, and there's nothing else. I don't use the cell diagram. So I'm trying to give you, this is the ones I have used, and I probably have some of them already printed up, so I wouldn't end up using them again. And I'll go to the other. This is B, and B is more about what we kind of looked at last week, the conducting system information. And not that graph, or more. That's more the physiology of it that are there. This certainly 17.13. So it'll be, and there's really 5 structures potentially that I could choose from: the AV, the SA node, the AV node, the interventricular bundle or bundle of His, bundle branches, and that subendocardial network. Well, good there. And then a couple on the EKG, and that's it. Not that. That did we or not do the cardiography unit, or we did? We did not do it. Talk to me. I have too many classes. We didn't do this piece yet. Ooh, really? Ooh. Uh-oh. Wow. Okay. So I hadn't done that part yet. Son of a gun. I'm confused about the other class. Never mind. Record what I'm saying. The exam will not be. Is somebody not going to be here 2 weeks from Wednesday? 2 weeks from today. Today is the what? 20. Are you going to be here on the 29th? You're not. No spring breakers early. You're not. You're not taking off for Boca again. You're not. You're going to Cancun this year. I'll tell my daughter. Maybe she can tell you where to stay. Pick on Riley Day. You got it. It's a good day when you could do that. For those that don't know, I am elderly. I now have my first 40-year-old child. It's all right. My other one's going to be 39, going on 16. My daughter will be 37 in 2 weeks. Anyway, so we'll make it in 2 weeks, and I'll skip the blood vessel stuff till next time and add that to this, and I'll do the EKGs here. Okay. Happy dance. So I'll get most of this. So because I did this unit with my phys lab, and I thought I had done it with you. I'm sorry. So I'll come back, and nevertheless, we'll look at this. Here's the EKG part. It's physiology. I like to do it in lab because next time I can show you some of the ones I've recorded from some of the students. So it might be worth. I can set that up for next time when I come here, just as well. I'm sorry, I thought we did it, and because of that, there'll be one where there's about 4 different tracings. Okay, these are tracings. So what you saw previously, I'll just back up a little bit going forward. That illustration is on it, so you identify the wave numbers. I know not everybody's in nursing. The reason I go over this, I do not know where, for those who are going to endeavor to go into nursing, where you might go, but I know what happens at UPMC, which employs a tremendous amount of people, not just in this area, but all over. If you want to go into cardiac care, ER, OR, recovery, ICU, CCU, you get the idea. In order for you to do certain roles there, you have to become certified in this. You have to be certified in cardiac med. You have to be certified in EKG. What does that process entail? I don't know. I can tell you what it did entail 2004 because my first wife did this. She had she was hired for Shady Side, and she ended up working in outpatient surgery, outpatient procedures, with an RN and a BSN. And what they did when they hired her, when she wanted to go there, she had to do the course in cardiac meds and the course in EKG. Here's what happens: they had all of it in Montefiore. So I remember driving her there every day because I was only working part time at the time. And drive her there at 8, pick her up at 5. Monday through Thursday, there was 8 hours of classes, whatever breaks they had for lunch or whatever. Every night there was homework, and on the Friday there was a giant exam that you had to pass. I don't. These days you have to have certification because if you don't, and someone makes an error, it's all about liability. Okay. For instance, I do a blood lab with my other students. They won't let me do it with you. They won't let you guys use a glucometer to prick your finger. I've asked 16 times. I get the same thing. Our insurer won't approve it. Not my call. Not you certainly could do it, but it's liability. Hospitals are no different. Everything is vetted. When I was pointed on more than one occasion to hospital staff to do surgery, I have to supply all my transcripts, my board certifications, all my letter from my mom that I'm allowed to go operate on somebody. My mom was reluctant to sign, but you get the idea. So that's why I go over this. If anything, just to give you an introduction, you'll go over it again and again, and it's true for a lot of areas. So that's the backstory. I'm glad I didn't do this with you, so I could remember to tell you that. So when we'll talk about what makes a normal sinus rhythm, here's the hint. Normal has a lot of shades of gray. The most important thing is that the atria, that's called a P wave, are followed by a QRS every single time. P wave, QRS. Anything else doesn't really matter as much, but that means the atria and the ventricles are firing. That's normal. Okay, I beg your pardon. That's sinus rhythm. Means the SA node or the sinus node is doing it. Normal has to do with how rapidly or slowly. As long as it's between 60 to 100 beats per minute for a normal individual, it's called a normal sinus rhythm. So understand, there's the little nuances of the words matter. This is not a sinus rhythm. No P waves are there. Okay, you have a QRS and what's called a T wave and some other changes that I'll review. This is called a heart block. You can see there's some big gaps here. That means every signal is not getting through. I'll explain what it is. And this is the very, very famous VFib. This is when the heart basically it'll be succeeded immediately, shortly by full-blown cardiac arrest. Just like what happened in the football games at Damar Hamlin. Maybe he started with this. It doesn't. It's a matter of seconds because blood's not being circulated, and sooner or later, everything's going to shut down. And typically, very, very much sooner. So those are the pieces to be on there. I'll do that now, and I'll take a look at this, and maybe I'll introduce the blood vessels. So I apologize. Let me go backwards. Fond of doing it. So I don't have any more illustrations from that unit to point out, but I do want to do the other one so we have them down, formally that's there. The other chapter that we're doing, and we'll do the blood vessels, but I will say that for next time, is chapter 13. 13 is the nervous system, and the eye and the ear and some of the nerves. I'm just going to show you, there isn't going to be as much, I think, as heart and blood vessels, and this was a while ago, so I understand it. I don't even know if there's anything on A until we get to the eye. And I don't think there is. That thing with the referred pain is not on there. The different arrangements of little sensories, not on there. That's on there. Okay, so when we start looking at the eye, I can do iris, pupil, sclera, okay, 13.3a. And I could use this 3B, 13.3b as well from a different perspective. And sometimes I will, to be fair, put two illustrations, put them together and it'll be, I might have a label on two from one illustration, one from another, all on the same question. Okay. No, as much as I'm very fond of that. No. No. So yeah, this one, yes, 13.6, because I've got all the layers. That one I definitely do, and I have a lot of other structures. I mean, this is another one conceivably you could use twice because you could identify the lens, suspensory ligaments, ciliary body or ganglia, etc., etc. Okay, so 13.6 you could probably use twice. And I don't think there's any. Yeah, there's the same. And I wouldn't use that. And I wouldn't use that. And I'm not going to do the cell one. That to me is more physiology. There or that one, even though they're interesting. Okay. So I figured I'd throw it. Not that. Okay. So that was 13A. I think 13B is a lot of physiology. I will go through it. There are. It's more the eye physiology. And I know this is something that you've covered previously. So again, to me, this is more the physiological aspect, not the lab aspect or the color blindness or any of that, and bleaching and cis and transforms and all that good stuff. Love that. I don't know. I honestly do not know if there's anything on here of any significance. No. Uh, I frankly, I don't know that I would include this other than in the context of being the first cranial nerve. So I don't think I would use that illustration or the one with all the different taste buds. I think I'd skip that as well. So I want to get to the ear next. So there's nothing on 13B. All right. Some ear is definitely on there. So I typically, they separate the two of these. So I don't think the external ear is too much, but the ones that have the internal here, whether it's this one, but more likely this, the 1321B. And you could guess the question, name the bones. Right? Is that hard? Cochlea 1322, cochlea semicircular canals. The nerve components. You might, I know utricle and vestibule. That's more than you would need. And I think there's one more that I use, not that one, but this one. So to know that that's the scale of media, that's the scale of vestibule, that's the tectorial membrane, that's the basilar membrane. Those would be the points. Yes, ma'am. Sure. This one? Yeah. 1322. So, you have two nerves. Now we call it vestibulocochlear. We used to say auditory, but we know it's more. So the cochlear portion is going to the cochlea, the spiral organ of Corti. This is going to the semicircular canals. And it enters by way of the oval window force, and it exits by right below it by something called the round window. And the utricle and the vestibule. The utricle goes into the semicircular canals, and the vestibule opens in more or less here into the cochlea. Okay, good to go. Sorry. Now I think that one of those with the tectorial and the basilar is enough, and I don't think there's anything else in that to worry about. Yeah, nothing here. Obviously with a lot of these, I don't think I do the one with the otoliths. I do love that stuff.
Will this be strictly diagrams?
Yeah, diagrams. Yeah, so it's going to be, A and a space and, utricle, B and a space cochlea, that type of thing. It's a 1 credit lab, for goodness sake. We're trying to get you through this. Don't thank me. Money. I didn't. I didn't say that. I'm going to get myself fired. Not that funny. Believe me, I'm not tenured. If they want out there, Lou, you're gone. See ya. No. Yeah, yeah. I mean, there's so much stuff. I'm trying to pick out ones that I think are not the healing of the peripheral nerve. I use this for the cranial nerves. I would surely on this. It's pretty hard to distinguish down here, but the first six, 1, 2, 3, 4, 5, and 6, would definitely I think be fair game on that illustration. And whatever one that was 1333A. I'm trying to think if there's any other ones in this. I'm fond of that, but I don't know if I put this in, I would give you all of this so you'd be able to know it was the trigeminal nerve. The same way, if I did the facial nerve, I would try to include all of these so you would have an idea. Basically, it would be almost freestanding. Which cranial nerve is this? So the only ones that really the illustrations tell the tale would be trigeminal, facial, and I think vagus. We're doing the ears separately, so it's not going to be there. This is the vagus. So that one illustration, there's no other nerve that goes to all the other organs. It goes to your heart or your stomach or your liver, etc., etc. Okay. So I mean that it should be a slam dunk. No, I'm not worried about the accessory nerve. Like I said, yeah, you certainly would know this was going to your tongue. So I mean, I might take three of those illustrations, the trigeminal, the facial, the vagus, the hypoglossal, and say, have that would be a one station and say which nerve A is what, and you give me the name of it or the Roman numeral. I don't care. And not worried about that. That's too busy. You can't see anything. Same here. Here, I am much more inclined to look at the plexes. So, I'll show you this one. So you would certainly know because you can see the shoulder, and hopefully you would be able to identify a particular nerve. So maybe, and again, I might have two or three of these. 1337. I could point to something. At least you would know it, or I'd give you some additional information. This would be more likely 1337C. I think you can tell just by the course. Yeah. Yeah, and maybe 1338B, because you surely would have a pretty good idea about this. And the way you're able to see it, it has to be lumbar plexus because the obturator nerve goes through the obturator foramen, as opposed to the sacral 1339, which would be this one, B, because you can see it's roughly going through that sciatic notch area. And you can clearly see this is posterior popliteal, back of the knee. That's done. Okay, so we did the heart and we didn't do the other guy, right? Oh, I am awful. I'll do that. Besides, more fun anyway. So normally when I do this, I set up, and I had trouble with it with my advanced phys class. I had two volunteers, and we do their electrocardiogram. So it's easy. You just put like we did here, a sensor, a sensor, a sensor. That's just like three sensors, pickups, and something on their thumb. It's because you were marrying the electrocardiogram with the pulse, and it just didn't do well. And I'm going to get in contact with the people who make the unit. It's vibrating too much, and I have had that problem here. And we've even tried extra ground, and it didn't work. But all that aside, let me get going. Okay, so that's not it. That's the hard sound. Is this A or B? That's B. Good. Off we go. The conducting system. The whole ball game with regard, so this is PowerPoint 17B, which is the physiological PowerPoint. When we come back from after the spring break, coming up not too distantly from now, understand, and it's the same, like with Thanksgiving, it's worse, because then immediately you only have 2 weeks left of class. Here you have about 5 classes left, basically after spring break, right? That's about it. So there's not a lot of time. So we have to get in pulmonary, digestive, urinary, repro. So I want to get everything else done before that. We don't do the immune system. I'll probably touch on lymphatics in the context of doing circulatory. And so I want to get the circulatory and anything else in, and maybe even introduce respiratory before we go away for break. And then, because we probably only have 4 or 5 weeks after that. Okay. Pacemakers. All of you with AP1, okay, you know about resting membrane potential. You know about the neuromuscular junction. What happens? We send an impulse, and basically it says fire. It's a voluntary process. This is not voluntary. This is involuntary. And what it means, a pacemaker indicates that these are cells that have the capability of spontaneously reaching threshold. And they do so consistently, and they do so at a very, very specific rate. So barring injury or illness or blood supply or heart attack or whatever, and sometimes medications obviously can influence these, for most of us, depending on what we're doing. If you and I are sitting here, okay, your heart rate's fairly stable. If you're lying down in bed, it's fairly stable. How do you alter it? When you go to the gym and you work out? You're outside doing the sport. Maybe it alters when you eat a lot, or certainly if you drink a lot or anything like that. So there's different things that impact it, but in general, what's meant to be pacemaker cells, their resting membrane potential is unstable. Why is it unstable? Because they have certain sodium channels that leak. Remember that whole thing in AP1 of resting membrane potential was you had potassium channels and you had sodium channels, more potassium, and set up roughly, it would have been minus 90, but the sodium being pulled back in made it minus 70, and voila, there we were, right? Ringing a bell? You're comatose. Watch out. So this is what happens. Voila. Think of it this way. The cell undergoes an action potential, goes back to its resting membrane potential. Does it stay there? No. Because there are sodium channels in there that are inherently, pardon the expression, leaky. And it's not as specific, they just continue to leak out sodium, okay, or beg your pardon, leak in sodium, and that brings it closer, and then effectively a set rate reaches potential. You'll notice, without going to the physiology, it's a different action potential. The action potential when we look at the pacemaker cell and when we look at the cardiac muscle firing do not look the same as we looked at the skeletal muscle or at a nerve. We don't get that sharp spike, okay? By definition, it's a more prolonged potential because that's a muscle that's about power and endurance and repetitiveness. So it isn't like we fire it once. We're firing consistently at a set rate, constantly, and we want it to be maximally efficient. We want it to squeeze out the appropriate amount of blood with the appropriate force each time. So it relies on not the sodium channels. This happens to do with calcium. That's why, if you remember, we talked a little bit in A and P1 about smooth muscle. It relied on calcium. Most of the calcium, unlike skeletal muscle, which is inside the muscle to start in the smooth endoplasmic reticulum, It relied on calcium from the outside. The heart's the same way. There's some inside, most of the calcium comes from the outside. So that's why, whether you're treating blood pressure problems like high blood pressure or heart problems, okay, one of the mainstays, I take one, is called a calcium channel blocker. It blocks the inflow of calcium. You're going to be in nursing. Every single patient who's older, sick, heart disease, high blood pressure, they're taking a calcium channel blocker. One I've taken has been around forever. I prescribed it for patients myself, called amlodipine, known as Norvasc back in the day, one of the earliest ones. When they're around that long, they're generally pretty safe. So that's the backstory. What happens? There's a set sequence of events. Okay? This involves what's called the conducting system. I'll show you the illustration like I did before again. That's one of the ones that'll be on the labeling exam, practical. It's all designed to make sure that the sequence is maintained each time. The atria fire relatively slowly. They top off the ventricles. The ventricles fire rapidly because it's their job to distribute the blood all the way to your body and with enough oomph, as it were, to get through a relatively slow circuit all the way to your lungs, be reoxygenated, and come back. Every time, more rapidly. Here I go again. More rapidly than once a second, every effing second of your lifetime. Don't start. SA node. It takes less than a quarter of a second. You will see, and I commented on it for those who have me for lectures, most of you did, in AP1, something called absolute refractory period. The heart's got it made. I want that contract. The heart, every time it beats, every time it fires, it gets a quarter of a second off. It only has to fire for less than a quarter of a second. It gets a minimum of another quarter of a second off. That's like you have an 8-hour day. You work for 2 hours. You're guaranteed a 2-hour break. I want that job. To some extent, I have that job. I don't work hard. I'm hardly working. Okay. So from that node, the pacemaker, the leakiest channel, it has the SA node. That's what it's known as, sinoatrial node. Unless otherwise specified, that's your pacemaker. It's supposed to be. When it isn't working, there's a problem. Why doesn't it work? Former heart attack, bad blood supply, medications, trauma, infection, etc. That signal is carried to the next node, called the atrioventricular node. Effectively, what has happened in that, this is the longest part. The part from the signal starting here and going through here, until it gets to that atrioventricular bundle, it takes up the bulk of that 0.22 seconds. The rate determining step is what we say in chemistry. The slow part, because it has less of those voltage gated channels, okay, inherently slower is the AV node or atrioventricular node. The SA node is in your right atrium. This is in the interatrial septum between the right and the left. Once it gets through there, everything's super fast. It carries the signal rapidly to the ventricles, all the way down to the apex, the tip of the heart. And then that elegant diagram takes place where the spiraling of the muscles, they squeeze, they fold, and it ejects the blood very efficiently. That last portion of it is by way of the atrioventricular bundle, the right and left bundle branches, and what we used to, and still I still call it the Purkinje fibers, many do, the subendocardial conducting network, all very fast. That's how it works. Pacemaker. The polarize, if it fires the fastest, the whole idea, again, go back to the DeMar Hamlin saga. What were they able to do? They defibrillated him on site. Okay, that's why we have, and I say it all the time, in the buildings, you have those AED, those automatic electronic defibrillators. We have chips, they're all chipped, they do it themselves. If you have any idea how to work it, all you really have to do is hit the on switch and put it where it's supposed to. It reads the rhythm. If it's a shockable rhythm, it figures out how much you're supposed to shock it and tells you to clear. And as long as you know where to put it here and here, you're golden. Okay, that has changed dramatically. We realize now, years ago, if you started CPR, you have what's called a witnessed arrest. You're walking, you see somebody goes, "Oh my God," falls down and go there in full blown cardiac arrest. You start CPR. Statistically, there's a 5 to 15% chance, even if you're trained in CPR and started right away, that that person will die. Just is. If you have an AED unit available and can defibrillate a defibrillatable rhythm, that lowers the number to around 1 to 5%. 95 to 99% of those people survive. That's a big deal. That's why defibrillation is now the key. Most of the state of Washington did most. They were the ones who really started CPR. They were really ahead of the learning curve with this. Uh, you guys in nursing, did they have you do CPR, cert? Yet? Some of you already were, I assume. But I mean, yeah, it's got to be part of it. We started doing it when this really came to the first time I did it in 1977, and the last time was about 2000 because doctors in the hospital, like in an operating room, you have to obviously be certified. Again, legalities, like I was talking about before, the vetting process. So typically for most of us, around 75, 60 to 80 is normal. It's a very good measure of your overall health. If you're between 60 and 80, if you're someone who's a well-conditioned athlete, particularly an endurance athlete, that number is typically a little bit lower, 50 to 60, because that means you have more reserve. When you have to go under maximum stress, your heart's got a lot of ability because everything is governed. Our heart rate without the vagus nerve would be well over 100. So that first impulse across the atria, they start to contract, they squeeze the blood in. Happy dance. Effectively, the way I view it, they're topping off the tank. We want the heart to be maximally efficient every time it beats. The only way to ensure that is that it's filled, because as you will learn, and did you get the heart unit in physiology and lecture? Yeah, they talked about the Frank Starling one and end diastolic and end systolic volume. Yeah, didn't. Not that I don't view this as an invitation, but you guys can show up in my office or send me questions if you have questions. I'm happy to do that. That's why I do what I do. It's even at home, I get back to you real quick. It's me or the dog, and the dog does not answer his emails. The cat does, because he gets up on top of these. You know what I mean? Like, who are you emailing? So, moving on. That signal goes to the AV node. It's inherently, remember, we only have 0.22, a tenth of a second. Nearly half of that interval is at that node. It's being delayed to adequately top off the ventricles. Fibers are smaller, fewer gap junctions. Make sure that the atria contract before the ventricles so we get maximum effect. In the absence of the SA node, the AV node can take over 50, max of 60 a minute. Not enough. You can live with that. You can't do very much. It would be hard for you to have it. Like if you had a day where you had to go to the grocery store, go here, go there, you'd be fairly exhausted. You have to take a lot of breaks. Believe me. Once it's through there, it rapidly, the bundle of His, what's important about this, it's the only connection between the atria and the ventricles. If someone has a pacemaker inserted, years ago we used medications to treat arrhythmias. They have a ton of side effects. It is much more efficient with modern technology to implant a pacemaker. When they do so, it's a little device that regulates, but you have to have a connection between the atria and the ventricles, because if you're using that, most likely the AV bundle ain't working. Then it divides going right and left. Those are called bundle branches. And lastly, we get to this, which are called Purkinje fibers, or now more modernly the subendocardial conducting network. So it goes all the way to the apex, to the tip, so to speak, much more on the left. It could conduct. It is leaky. But 30 beats of a minute, you're going to die. You're going to go to AFib and you're going to die, or VFib and you're going to die. So again, 0.22 seconds, there's the illustration. And this, if you go through the PowerPoint, which you have, it does that. It tells you what happens at each of the places. Got it? Good. Defects are called arrhythmias. You lose the coordination. The distinction, fibrillation, which you heard me mention a couple of times, like defibrillation. The contractions are so rapid and so irregular that they are inefficient at moving blood around. So effectively useless. And if you're not moving blood, you've got about 6 minutes before brain death. And brain death is, in most states, is death. So the whole idea of defibrillation is you're shocking it, you're depolarizing all of the cells in the hope, if you're fortunate, that the SA node will effectively reset and take over again. And sometimes you have to do it more than once. It's remarkable if you've never seen it. First time, I don't know what it's like today. I haven't seen it recently. The first time I saw it, my first wife, before we were married, and she's an ER nurse. I'm walking in the ER to pick her up at the end of shift at 11:30, square 311. And all of a sudden, I see this, she's 100 pounds soaking wet still. Hop up on some guy on a gurney, goes, he's coding! Wham! With a precordial thump where they take their fist like this and wham right in the, starts the compression. Then she hops up because they shock him. And the guy, when they shocked him, he went up like 2 feet. Like in the movies. It was impressive. This tiny little girl. Okay. So when it's not where it's supposed to be, we call it an ectopic focus. Ectopic means something happening where it shouldn't be, like an ectopic pregnancy. Junctional or nodal rhythm, you'll see the illustration. Extra beats. They're more common than you think. Okay. And typically, if it happens out of sequence, periodically you'll get not enough blood and then you'll have an overload. So that thump can happen. And what's interesting about it, what I've experienced, it caffeine. Okay. Caffeine can do that to you. And a lot of people will, and the good thing about caffeine, when you stop, it kind of goes away. Okay. And so whenever it can't get through, you have varying degrees of heart block. Heart block can be as simple as a delay. It can be like the one you're going to see the illustration of, every other. And then you can see a complete heart block when hopefully the AV node takes over. That's called a third degree heart block. So in the old days, we had first, second, and third degree. Now they're fairly specific. So we're going through that just to show you what the cardiogram is. And here you can see it. Remember, this in red, this is tension. In blue, this is cardiac muscle. It's not, the muscle doesn't fire and then magically relax. It doesn't depolarize. Look at that prolonged plateau. Calcium. So it allows the heart muscle to be more efficient at what it's doing. So you can, it's not something I'm going to ask you about. Maybe they'll ask you about in lecture. I don't know. Okay. I love doing AP2 lecture, but I haven't done it here in a number of years. Every so often I do it during the summer. Which brings us to this. Resource. This is not a secret. Anybody can do it. It's called ECG Library. This is a tough one. Google ECG Library, and you come up with ECG Library. Voila, there it is. .com. Been using it for, I don't know, 15 years. What is an electrocardiogram? C or K doesn't matter. I say EKG because I learned that. It's the hard K in the German for cardio versus the typical C we use to C here. It's all differences. Okay. It is based on this. Okay, not the history, this thing. It's called this is what you get out of it. It's called the electrical axis. So, one, think of it as all the action potentials and you're getting a tracing of. Typically, you get the classic EKG is a 12 lead EKG. We'll show you a picture of it. Every year, I typically, when I go to the doctor, they send me over to the hospital and you get a check, whatever, EKG, some blood tests, usual stuff. When you reach a certain age, that's par for the course. If we don't use the cardiograms as much as we used to, they used to be the part of the criteria how we diagnosed heart attacks. It's changed. A lot of them, and I tell this anecdote now over the last couple of years because it happened to me. Here, at UPMC, you get a report. So the report says, here's what the report said. One year it said it was read as normal. The next year it said, please review for possible cardiac event, possible heart attack, and then underneath it, same as last year. Understand, I called up I just made him retire. I'm convinced. Okay. And I called up and I said, Fred, as you would talk to someone you would call on a first name basis, WTF are you talking about with a heart attack? He said, oh, those are now machine read. He said, and they've done this a lot. They look at the machine looks at it, the tracing, and gives the diagnosis. He goes, there's no heart attack. So he said, it's the same as last year. Okay. So to be clear, this is maybe not as much, and maybe they're not doing it quite as aggressively with that training, but I'm calling it to your attention. Effectively, what you're able to do by glancing at two of the leads, you can tell if the heart, and remember the bulk of the heart is pointing down and to your left. That's where the electrical activity should be focused. If it is not, it could have a variety of different causes. It could be on the opposite side, it could be above, or it could be completely opposite. Not down and left, but up and right. And it gives you an idea what they call that one up and right. I mean, it could be as simple as somebody put the leads on wrong. I mean, how obvious is that? Or you could have emphysema, or you could have ventricular tachycardia, or right axis. That's why these are useful. So effectively what happens, they talk about if 1 and V, okay, so if AVF plus VE are in the right places. So I'll show you what they're talking about. Then you go back up here, the normal electrocardiogram. This is what a 12 lead looks like. In the old days before we had this computer based, you would have it. There's a machine over there that does it. Okay. We don't use it now. It runs the paper at about 25 millimeters a second. And so, each of these little squares is 0.04 of a second. So a big red, deep, thick red line to thick red line is a 20th of a second. 0.2 seconds. 5 of those 25 little squares is a second. And so for years, you counted the squares. So this was lead 1, lead 2, lead 3, AVR, AVL, and AVF. So you looked at the QRS, the part that spiked that points up. If it was heat positive, pointing up in 1, and in F, part was in the normal, the electrical center of the heart was where it was supposed to be. And these are called the precordial leads, B1, 2, 3, 4, 5, and 6. So you can access this anytime. It's kind of neat to look at some of this stuff, if you wish. Okay. So I wanted to throw that in there for the sake of completeness. We're getting pretty close to when you won't have to be aggravated by me anymore. So that's what I didn't know about any of that stuff when I was in school. I was doing a program as a medical student, and I mean, the guys I was working with, they called them interns. They just graduated medical school. I was out of Medical College of Virginia at the Vets Hospital in Richmond. It's a giant Vets Hospital. And he's we're going to look at Mr. So-and-so's EKG. And he takes this little notebook out of his pocket. He goes, I'm like, what are you doing? He goes, oh, This is the electrical axis of the heart. It had it all written down. I was like a sponge there. I just sat there and read everything down. I was very quiet. It's great. It's like sucking up knowledge. Okay. Richmond's a nice city if you get a chance to go there. Okay. 12 leads. So it's all the action potentials at a given time. This is how we separate them. Letters of the alphabet. I don't know what happened up to O or after T, but other than that, they use P, Q, R, S, and T. Don't know the derivation. It is an electrical tracing. Know now that electrical events precede mechanical events. Just like we talked about in lecture in AP1, electrical events precede chemical events. The electrical first, then we reset the cell chemically, electrical events, and then the mechanical events. That's what happens here. So when you think about the heart firing, the first thing is electrical. It's called depolarization, as you know. It is not the muscle contracting. That is systole. The terms are not interchangeable. There are some who use that erroneously. It's like repolarization is not diastole, which is relaxation. So I'm not going to do it to you on a test. Somebody might. Yeah. That's how they try to trip you guys up. I'm trying to help. My questions are hard enough without it. You don't have to think. Those that perspire the most in practice lead us the least in battle. Okay? It's true. I mean, when the SEALs are going on a mission, they spend days scaling. They make a mock of the building, they scale it so that they can get out of there alive. Practice, practice, practice. Okay? It's true. I mean, my son's telling me on the ship, and he wasn't the captain then. He was like XO, and I think they had a small fire. They spent 2 days doing fire drills. So we had that fire. We drilled for 2 days, so everybody knows exactly what to do and exactly when to do it. Those people could die. So P wave depolarization, electrical activity associated with the atria electrically firing. The QRS, the big spike, it's 3 parts, Q, R, and S, is ventricular depolarization, much larger electrical event. It obscures the atrial repolarization. The T wave is the ventricles repolarizing, no other events like that. We look at PR and ST a lot. That's what it looks like. You have the leads, which we do in class. You used to put them on your limbs, here, 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 here. And then these are called the precordial leads. You palpate certain spaces, nipple line, intercostal spaces, side. And people, and the techs are very skilled in that. This is what it looks like. We look at that PR interval. These are each those 0.04 second squares. You should have between 3 and 5. This has 4. That is a normal interval allowing the heart to fill. The rest of the cycle takes very little time compared. So maybe this is a bit more than a quarter of a second. Not a whole lot. Everything is completely relaxed with regard to the ventricles firing. Now they just have to reset electrically in a matter of under 4/10 of a second. So we look at that. That if this is elongated or irregular, that's a kind of heart block. We look at the QRS. The electrical activity is so dramatic, we often see the Q wave go down. When that's exaggerated, typically that means that can be associated with an acute myocardial event, heart attack. We look at the R. We look at the height of that complex. If it's over a certain level, it's because the heart is too muscular. Unlike you and I, when we try to get into shape, okay, getting your muscles as big as possible might be useful, not in the heart. When the heart is too muscular, it is too difficult to generate pumping power. It can't stretch, that Frank Starling thing. that you tell me you might have heard about. Doesn't, because there's too much muscle. So that's a hypertrophic heart. Okay, enlarged heart. We see that with high blood pressure. The ST segment is the time between the depolarization and the repolarization. That is often evidence of old cardiac events, and we typically see depression or elevation. In other words, it's not a flat line going to T. It kind of comes down this way or up that way. Good enough. So I'll show you a few. So we look at these. There's the normal P wave, QRS, T wave. Count the squares, about 17 to 18. Those little squares, it's about 75 beats per minute. So it's not only is it normal, 60 to 100 beats, it's P wave, QRST, P wave, QRST. You want that. No P waves need apply. Notice the elongation. There's about 34 or so squares. That's longer than a second. That means your heart rate is less than 60. And no P waves. That's a junctional or nodal rhythm. Heart block. First of all, you can see there's not a whole lot of juice in this heart. Secondly, P wave, QRS, pardon my voice. T wave, P wave, nothing. P wave, QRS, T wave, P wave, nothing. It's in every other. So we call that a second degree. So that's a 2 to 1 block. Sometimes you'll see 3 to 1 blocks. And then VFib, very famously, the ventricles are firing randomly, irregularly. If you could hold it in your hand, it feels like a quivering bag, like you went fishing with worms. It makes me sad to talk about it, but I will. When I was a medical student, we did vivisections, dogs that we sacrificed. That's kind for cutting them up and killing them at the end. It's horrible. Medical students did that for a long time. And one of the labs I had, and we each took turns being like the boss of the lab. And the one I did was one of the ones where we actually had to feel that. So it's how they. I don't approve of it. It was awful. It was sad. It's so vivid, and this is something that happened to me nearly 50 years ago. I can still see it today. So that's the difference between systole, diastole. The other one, and I don't know if you didn't do this in class, you should have, and hopefully you will. That's marrying these events, whether they're cardiac, P wave, QRS, and T wave, to all of these events that you see here. The pressure rising in the ventricles and then declining, and particularly here, the pressure of the ejection flow from the aorta. It's got a very interesting little guy over here. That's called the dicrotic notch. That dicrotic notch is not an EKG. It is what happens when the blood flows. Those are elastic arteries. I talked about it before to you. What happens when they rebound, when the heart stops, when the pressure wave subsides, that rebound is enough to create a secondary force on the blood in the vessel. It pushes it farther along, and it pushes it back on the valves, shutting the semilunar valves, aortic and pulmonic, and it creates an extra of pressure. That's this. And what it does is, rather than the pressure being there and dropping abruptly like this, it is a much smoother. Okay, so it makes the flow of the blood much less turbulent. So, I mean, we have to have this sustained pressure to get the blood from your heart down to your toes with some juice to come back. That's what all that, and I felt that was important. Murmurs, irregularities in the valves, etc. That's the part I should cover today. What I want to do next time, and you can look at these, you'll see some great patterns, like acute anterior myocardial infarction. You can see these irregular waves. Look at the size of those Q waves going down. You begin to see ST elevations and ST depression, and it talks about them. Reciprocal ST depression in the inferior leads, ST elevation in V1 through 6. So you can see how it's sort of up here and it comes down, or down here and it comes up. So that's what you should be able to glean from these things. What I wrote up on the board is the next part that we're going to start. I tend to use this text uses a lot of these what I call pipe diagrams. Okay, which I've never loved, but they use them. So I try not to use those. Like I can't make head or tail out of that. Too busy. It's like wear one of those ridiculous Hawaiian shirts. Too busy. Okay, I like those. So the one I put up there, and I'll put it up again. It has a lot. It's sort of trying to explain this. It has to do with the blood leaving the heart and the three major vessels. One that crosses over to the right, called remember the heart's on the left, called the brachiocephalic trunk. Trunks break up into additional vessels. Versus on the left, it kind of goes directly off the aortic arch to the carotid and the subclavian. That's what I'm going to get all those through. We'll probably try to get somebody to volunteer or at least show you an EKG, and we'll stop it at that. And we'll do the exam not next week, but 2 weeks. Thank you very much. Go on your way. I'm sorry it wasn't 45 minutes. Kinsey, you're going to